And today the ground rounds is going to be Dr. Junkins, and again is here with us and our team at Norton Healthcare. Is directing all the microbiological activities here, and the topic we slowly we're getting deeper and deeper into each one of the areas that we want to understand better. And today, dissecting the susceptibility report. I don't know if this is microbiology or anatomy, but
not anatomy, no.
But I like very much the title. And Alan, thank you for taking the time, and please go ahead.
Well, thank you, sir. I don't know if dissecting is the right word or not, but it's what I could think of. So, yeah, what I wanted to do was kind of go over the susceptibility report. We've all seen the susceptibility reports. This is one of ours from recently in EPIC. So you've all seen things like this. And I just wanted to kind of go over what we do in the micro lab to kind of get to this point. So this was a culture. There's the gram stain. There's the culture results. This is an MRSA. And here's the susceptibility down here. So basically, there are two items on this report. There's the MIC, and we'll start with that, the MIC. So what is it? MIC is minimal inhibitory concentration, which is really a good name for it. It is the lowest concentration of antimicrobial that will completely inhibit growth of the organism. And the key there is inhibit growth. We're not talking about trying to kill the organism. We don't do that. What we want to do is we want to get to the point where we know we inhibit the growth and then let the human body take care of the actual killing. So when we are choosing whether to use something, we're trying to do it to the point of what do we need to do in order to inhibit the growth of the organism. And this is a really very simple concept, and it's a very simple thing that we do in the lab. We've taken the very complex stuff that's going on in the human body with an infection down to a very simplified system. So take a look at it. You got a bunch of tubes here with broth in it, and they're going to have different concentrations of antibiotic in it. So whatever antibiotic we're talking about here, let's say this is ampicillin. And the way to think about it is that we have 1 microgram per mil, and then you go by convention in twofold dilutions or a twofold increase. So you're going to go 1, 2, 4, 8, 16, and you're going to go down from there. So it's always done in this twofold dilution scheme. All we do is we take our bug of interest, the bug that we've isolated from this patient, we put it in each one of these tubes, and we watch to see whether it grows or not. So after overnight, this brown here is the bug having grown. So determination of the MIC, like I said, is very, very simple. This bug grew at 8, it grew at 4, but it did not grow at 8. So the lowest concentration that inhibited growth of the organism was 8. This bug has an MIC of 8 to this particular drug. So very simple concept. It's easy for anybody to kind of understand what's going on there. And it's very simplified the way it is done in that it's a pure culture in a broth, ideal growth conditions for the organism. The concentration stays at 8 the whole time. There's no, half-life or anything. It's going to stay there the whole time. So it's a very simple idea. Now, doing it is not quite as simple. There's a lot of rules for how you go about doing this. Clinical Laboratory and Standards Institute is the Bible that we go by. This is an independent organization. It's not affiliated with the government or accreditation, that kind of stuff. Independent organization, but they publish these guidelines for us, which tell you exactly how to go about doing susceptibility testing. So pretty much everybody in the world follows these guidelines. And we want it to be that way, very standard, this is how you do it, so that if I do a lab test here in our lab, and if I send the bug to University of Kentucky, their lab does it. If I send the lab to Vanderbilt, their lab does it. We all come up with the same answers. We all want to be consistent with what we're saying here. We want it to where, if a research lab, especially research labs that are developing these tests and developing new drugs, they should be able to do a result and get the same result that a clinical lab does. And ideally, if I do the test today and tomorrow and the next day, we want it to be consistent over time, as long as the bug doesn't change. So it's very highly standardized. Excuse me. We do the same method here that they do in Berlin, or they do in Buenos Aires. It's the same process, so that we should be consistent. Now, before we leave MIC, a couple things I just want to point out, because this is situations where physicians have called me confused before. Couple rules: don't compare the MIC between different antibiotics. The MIC means something within a certain drug. So if you're going to treat me with ampicillin, I'd much rather have an MIC of 0.5 than an MIC of 16, of course. But I don't want to compare between two different antibiotics. The lower number is not necessarily better. And I'll use this as an example right here, because I have seen physicians make this mistake. If you've got urinary tract infection caused by E. coli, I'll tell you, here's one that I read in Epic Notes. Patient comes in, has a UTI, doctor starts him on nitrofurantoin. Okay, excellent choice, sends the specimen to the lab. 2 days later, the lab reports it's E. coli, and here are your susceptibilities. And the doctor changes from nitrofurantoin to ciprofloxacin because it has a lower MIC. No, don't do that. You can't compare the numbers between two different types of drugs. Nitrofurantoin, the great majority of the time, would be a much better drug in this case than Cipro would. So don't think that the lowest number is the best drug to use. You can make a really good argument too that micro labs should not be reporting the MIC. Some labs do not report the number. And there's some benefit to doing that. One thing is that it solves this problem. If the doctor is going to choose the number with the drug with the lowest number, then don't even show them the numbers. Just show them the categories. Also, the MIC can be kind of confusing sometimes. I get these calls every now and then. Here's a MRSA. Cefazolin MIC is less than or equal to 4, so it looks like a really low MIC, but we're calling it resistant. Why is that happening? Clindamycin, MIC less than or equal to 0.25, very low MIC, but we're still calling it resistant. So there are some issues where MIC may not look like it correlates to the category that we're reporting. And there are reasons for those that hopefully we'll get to at some point. So back to the report. There's the MIC. The next issue is going to be the interpretation. How do we go from MIC to giving you an interpretation? That is based on breakpoints. The breakpoints are going to be those MIC concentrations where the interpretation changes. I told you determining the MIC was very simple. Determining the breakpoints is very complicated. This is the kind of stuff that's going to be done all during development of a new antibiotic, all the research that goes into it, all the animal studies, all the very early clinical trials of it. They're going to come up with all this information. They're going to look at the pharmacokinetics. They're going to look at the pharmacodynamics, how it behaves in that particular bug. Antibiotics will have to be categorized as either time-dependent or concentration-dependent. It's not just an issue of achieving the MIC at the site of infection. That's not the point. There's some antibiotics, what matters is how much time are you above the MIC. And some bugs, it depends on how far above the MIC you are. So with some drugs, you may have to say, we need to achieve at least 10 times the MIC before it's actually going to be effective. For some antibiotics, you need to say, we need to spend at least 60% of the time above the MIC in order for it to be effective. That's all really complicated. I'm not going to go through all that. That's a topic for one of our pharmacy people if they want to tackle that at some point. But notice also, it depends upon usual dosing regimens. How much is it common for people to dose this drug? What's the typical dose? Because that's going to be really important. But you take all of that, you put it all together, and you come up with a set of breakpoints. So for example, with this particular drug, you're going to say 1 or less is susceptible, 8 or higher is going to be resistant, and 2 or 4 are going to be somewhere in between. So the susceptible ones, this is about the best definition you can come up with. If we call it susceptible, we're going to say that the organism should be inhibited at the site of infection using normal doses of antibiotic. All right. Like I said, all that pharmacokinetic data and all that other stuff depends on exactly what you need to achieve at that site. But we're going to say if you're 1 or less, you should be susceptible. The drug should be effective. Red, if it's 8 or higher, it's resistant. Then we expect that the organism will not be inhibited at the site of infection using normal doses. Those are simple. That leads us to the yellow category. Most of these are reported out as intermediate. So the intermediate category has been around for a long time, for decades. And it was designed to be a buffer zone, because you're not going to get exactly the same MIC every single time. You may waver a little bit. Okay, so we didn't want a situation where a minor change in how the test was set up or a minor change in how it was read led to a major change in interpretation. If something goes from intermediate to susceptible, I'm okay with that. But if something goes from resistant to susceptible, then that can be a problem. So we like to have that kind of buffer zone there to be an in-between. But we also learned over the years that intermediate could also mean that the drug may be still be susceptible if you can give higher than normal doses. Remember, the breakpoints are based upon the normal dose that's used. If you can bump the dose up a bit, then an intermediate might be just fine. You can treat with an infection with a drug that's categorized as intermediate. Now, you'll notice more recently, we're seeing more and more of these called susceptible dose dependent. So we've been using this category for years for yeast. You may have seen, for example, the classic is Candida glabrata is never susceptible to fluconazole. It's susceptible dose dependent, but it's not fully susceptible. But we started adding it for some bacteria drug combinations as well. It's kind of started off with the enterics and cefepime. It's moved to the enterics and piptazo. There's this new susceptible dose dependent category. And CLSI and other organizations are going to be adding more and more of this category in the future. So you'll see it more often. And the reason is just to make it more clear to physicians that you have to use a higher than normal dose. Okay. These dosages are spelled out in the CLSI documents. No, we don't really make that easily available to our physicians, though. So who sets the breakpoints? There's 2 organizations that in this country are involved in setting the breakpoints. One of them is FDA, and I'm calling this manufacturer initiated because basically when a drug manufacturer has got a new antibiotic and they're going through all the research and they're going through all the clinical trials, all that data is going to be used to set the breakpoints, and the manufacturer will submit those breakpoints to the FDA at the same time they submit the drug for approval. And the FDA will say, yes, this drug is okay, we approve it, and we approve these breakpoints. So it's really the manufacturer that has suggested and provided data to support a certain set of breakpoints. Then what's traditionally been done is that FDA does not go back and re-examine those breakpoints. unless the manufacturer requests a re-examination of breakpoints later. What we all tend to live by in microlabs is CLSI again. This document is published every year, usually in January. COVID kind of threw it off a little bit, but it's updated and published yearly. And this contains tables with all the breakpoints that are determined by CLSI. Like I said, CLSI is an independent organization, a bunch of microbiology and pharmacy experts who get together a few times a year, and they look at data that comes from manufacturers, it comes from research labs, that comes from their own clinical laboratories, and they decide what the breakpoints should be. So you can imagine that sometimes the breakpoints at CLSI are different from those that are set by the FDA, which always causes us a big headache. Now, they're trying to get better at this. In 2016, Congress passed the 21st Century Cares Act, which provided, among a whole bunch of other things, it provided a mechanism by which FDA and other organizations such as CLSI get together. And so we now have this website here that FDA publishes and updates every 6 months, where they provide breakpoints, and here are the ones where we agree with CLSI, here are the ones that are different, and they will examine those. There's still some differences between them, which means, I could say a bug has an MIC of 4 and is susceptible because I'm using FDA breakpoints, and somebody else may be using CLSI breakpoints and say I have a 4 and it's intermediate. So you will get some issues like that, some differences between. But we're trying, finally, after decades of having this problem, we're finally starting to see some effort to get together and share data and have the same breakpoints. So this is just an example of a table from the CLSI document. This is the enterics with cefepime. So you can see here, this is one that has the susceptible dose-dependent category. So less than or equal to 2 is susceptible. 4 through 8 are susceptible dose dependent, and greater than or equal to 16 is resistant. Notice it goes in that twofold dilution scheme. So you can see it over here, breakpoint for susceptible based on the dosage regimen of 1 gram administered every 12 hours. But the breakpoint for SDD is based on dosing regimens that result in higher cefepime exposure, higher doses or more frequent doses. So for example, if you could do 2 grams every 12 hours, you could use SDD. Or if you did 1 gram every 8 hours, you could use SDD. So a little bit of a difference there. And I just wanted to put this in here to point out that they're not the same for all bugs. Okay, this is vancomycin. You can see it's different between Staph aureus and all the coagulative staph. Enterococcus is different from Staph aureus. So there are differences from one bug to another. You can even look at strep here. They have a susceptible breakpoint. They don't have breakpoints for intermediate or resistant because there's never been any. We've never had a vancomycin resistant strep. So until we start seeing those, in other words, as soon as we start seeing strep that have MICs of 2 or 4, then we're going to have to start thinking about what categories those should be in. Now, if you're looking at this, this is the way I showed you before, how we do it. Imagine these are all test tubes here. But if I look at this is 14 different concentrations of the drug. And if I wanted to be able to report out 10 different drugs, and in our lab, we do about 200 different organisms a day, susceptibility-wise. That would come out to 28,000 test tubes a day. We don't have space for 28,000 test tubes. So we don't have people who are going to actually look at those test tubes and read them. So labs don't do it this way. This is the simple method, but this is not the way labs are going to do. This is what we actually do. This is an instrument called the Vitek. It uses these little cards like this with all these little tiny wells in it. This card is about the size of a credit card, a little bit thicker than a credit card. And this is a Phoenix, which uses these larger panels that look like this. You can see all these wells. So lots of different space for drugs on there. And what we use in our laboratory is a microscan walkaway, which uses a 96 well microtiter plate, just like this. But still, go back to that example, if I wanted 10 drugs and 14 different concentrations, that's 140 wells right there. I can't do that even with the biggest of these panels. So what we do is what's called breakpoint testing. Breakpoint testing is we only test the concentrations where the interpretation is going to change. So for example, this is tobramycin with Pseudomonas aeruginosa. Here are the breakpoints. Less than or equal to 4 is susceptible, 8 is intermediate, greater than or equal to 16 is resistant. So all we really need to do is test these two concentrations. If it doesn't grow at 4 and it doesn't grow at 8, then the MIC is less than or equal to 4 and it's susceptible. If it grows at 4 but does not grow at 8, then the MIC is 8 and it's intermediate. If it grows at both, then it's greater than 8 or greater than or equal to 16, and then that's resistant. So instead of doing 14 different concentrations, I only have to do 2. This is great for us because I can take that 96 well plate now and do up to about 30 drugs on a single panel. A lot more antibiotics can be tested on the same real estate. The disadvantage is I'm not really getting a true MIC anymore. I get doctors and pharmacists who call me up and say, you're calling this less than or equal to 4 susceptible. Okay. Do you know if it's a 4 or is it more like a 1 or is it more like a 0.25? And all I can say is, yes, it's in there. Pick a number below 4 and it's one of those. You know, we don't know exactly where it is. So you're not getting very specific information out of it. Same thing with resistant. You know, can you say, is it a little resistant or is it really resistant? I don't know, but all I can tell you is that it's resistant. So we're not really getting a true MIC out of this. If you want a true MIC, one thing that you can do is an e-test strip. We're trying not to call these e-tests anymore because that's a brand name. There are several companies that make them. So we're trying to use MIC gradient strips, but it's hard. Most labs use these to a certain extent, but not routinely. Here's what it looks like over here. You take the bug of interest, the bug that's causing the infection, you swab it over a plate. So you're going to have confluent growth over the entire surface of that plate. And then put down one of these strips. There's a gradient of the drug, a lot of drug up here and very little drug down here. So after you incubate it, you're going to get this zone of inhibition where the bug, the concentration of the drug is too high for the bug to grow. You can read the MIC where it crosses here. So this one crosses between 0.75 and 1. I have to round up. I'm going to call that an MIC of 1. So it's great. We love these things. You get a full range of MIC values. This one goes all the way from 0.016 to greater than 265. So I can tell you exactly what the MIC is. And these also are nice because they become available before they're going to be put on our automated panels. So we can, some drugs that are new, that have only been out for a year or two, we can do e-test on them, but we can't do the regular panels. But here's what's not so great. It's not automated like those panels are. So it takes more work to set up. It can be really hard to read the results. I've given you a really easy one here, but some of them are much more difficult to read. And it costs a lot. For us, we pay between 33 and 50 times more money to do one drug than we would do if we were testing the panel. So we don't use them routinely. Special request testing of antibiotics that are not on the panels. If there's a drug that's just not on the panel, then the only way we can do it is by e-test. Certain bugs won't grow on those panels, like Haemophilus. And as I'll talk about in just a second, for confirming unexpected results, something that's not supposed to happen, we can try to confirm it with a second method, and we'll use e-test for that. So most labs have these, and we'll use them, but we'll use them for specific purposes. So that's the report. Let me get to the next thing, is actually creating the report. Here's the printout that we would get for our microscan instrument. Lots of different drugs with MICs and interpretations. So we got the MIC, we got the interpretation, but we want to actually take this to make the report. And the key thing there is, do not report every drug the machine gives you. Do not report every interpretation the machine gives you. You have to have some thought about it first and whittle this down to something that's going to be more appropriate to use. So 3 steps I want to go through. One we just kind of mentioned, check for rare resistances. This is another table that CLSI gives us of things that just shouldn't happen. So this category 1 here, not reported or only rarely reported to date. For example, this is Staph aureus, vancomycin resistance, not reported or only rarely reported to date. So if we put a Staph aureus on our microscan and it comes back saying it's vancomycin resistant, don't believe it. We should not believe that. We should catch that before it actually goes out to the physician, okay? We have to confirm that before we report it. So first of all, make sure the culture is not contaminated. A little bit of a gram-negative rod mixed in with that Staph aureus would give you vancomycin resistance, for example. Can't really trust that panel, so I better repeat it. I can do an e-test as well to see if both the panel and the e-test agree that it's vancomycin resistant, and confirm the identification. Make sure that this really is Staph aureus. So these are things that you need to catch, or your lab needs to catch before they actually get reported out. There have been cases of vancomycin resistant Staph aureus being reported in Kentucky that luckily were not true. The other thing to do is check for things that are supposed to be resistant. So here's another table from CLSI which shows you some intrinsic resistances. Intrinsic means all isolates are resistant to this, even if they test susceptible. So we need to look at things like this. My favorite is Stenotrophomonas, because look at all these intrinsic resistances for Stenotrophomonas. Every single one of those. We should never report Stenotrophomonas as susceptible to any of the carbapenems. Okay, it's resistant to all of them. Never reported as susceptible to any of the aminoglycosides. So even if the machine measures it as being susceptible, we have to change the interpretation to resistant. Or the other option is don't report the drug at all. And if you have to do something there, make sure you've got the right bug. If you've got a bug that is testing, if you have a bug that you think is Stenotrophomonas and you think it's testing susceptible to the carbapenems and to tobramycin, then maybe it's not Stenotrophomonas multifilium. So you have to use the susceptibility results to kind of quality control the identification results and vice versa. So check for things that shouldn't be resistant, check for things that shouldn't be susceptible. We have to do that. And then the last thing we do is selective reporting. We don't report every single drug that comes off the machine. This is really important, I think, for good antimicrobial stewardship. We want to try to lead the physician as much as possible to choose an appropriate antibiotic. So these things over here on the left are things that the micro lab has access to, and we can kind of formulate our reports sort of based on this. It's got to be a drug that's appropriate for the body site. We would prefer it to be a fairly narrow spectrum drug as opposed to a broad spectrum drug. And it would be preferable to be something that was fairly lower cost than a really expensive drug. These things on the right side are things that we are not going to have access to. We're not going to be able to use these to formulate the susceptibility report. These are all things that we're going to depend upon the physicians and the pharmacists to whittle down our report more to find the one most appropriate result. So let me give you an example here. This is E. coli from a blood culture, and this is one of the panels that we use for susceptibility testing, and all the drugs that it reports and the interpretations. So this particular panel will give me 29 different antibiotics at one time. I am not going to report 29 antibiotics on this particular patient. So we look at for a few things. First of all, look for things that are not appropriate for the body site. So nitrofurantoin is a urinary tract drug only. You do not report nitrofurantoin on a blood culture. So we're going to get rid of that. Same thing really with tigecycline. Tigecycline is not good for bacteremia. It gets into the bloodstream, but then it's quickly sucked into the tissues. So you can see the breakpoint here is less than or equal to 1, but you'll never really achieve 1 in the bloodstream. So we have to wipe those out. So we're not going to report tigecycline or nitrofurantoin. Then you got some other ones here, and I'm gonna just say here in our particular facility that these are not on formulary. I know my pharmacy people listening may say, well, yes, they are, but I'm gonna say, we're gonna take those off because they're not accessible to physicians in our facility. Then we have a certain set of drugs here that our physicians could use, but we want to reserve them. When I say we, I basically mean the antimicrobial stewardship team wants to reserve these for certain purposes. We want to reserve ceftolozane, tazobactam, perhaps for multi-drug resistant Pseudomonas, if at all possible. Ceftaz, avibactam for carbapenemase producers, if at all possible. So we have certain uses for these. We don't want them to be in general distribution. So we're going to take those off. Then we're going to start looking at, yes, we are. We're going to start looking at spectrum. So for example, I'm going to give you ampicillin, but ampicillin is resistant. And since ampicillin is resistant, then we're going to step up and say, okay, I'll give you ampicillobactam and amoxiclav as well. Okay. I'm going to give you cefazolin, the lowest spectrum, narrowest spectrum cephalosporin here. But unfortunately, that's resistant. So now I'm going to let you have ceftriaxone. Okay. The ceftriaxone is susceptible. So I'm not going to give you ceftazidime. I'm not going to give you cefepime, and I'm not going to give you piptazone. We're going to take all those off the list. So among the beta-lactams here, ceftriaxone is the one we're kind of pushing you towards here. Fluoroquinolones, our fluoroquinolone of choice is ciprofloxacin for gram-negative rod. That's susceptible, so we're not going to give you levofloxacin. Okay, aminoglycosides, gentamicin for an enteric like E. coli, gentamicin would be the choice. That's susceptible, so we're going to take tobramycin and amikacin off the list. I'm going to give you trimsulfa, okay? You can make an argument. Obviously, there are some patients that you can't use trimsulfa with, and it may not be the best choice for a blood culture. In this case, it's resistant anyway, so, but we can make a good argument that we should not report trimsulfa on blood cultures, but we do. Which leaves us lastly with meropenem. And I'll be honest with you, for meropenem, we got a whole slew of rules that depend on whether you get meropenem reported or not, or any carbapenem reported. And we are not going to report meropenem on a bug that's ceftriaxone susceptible. So that gets taken off the list. So now I went from 29 to where we now have 8 that are actually going to get reported. And only 5 of those are actually susceptible. So instead of giving you 29 drugs, we're giving you basically 5 drugs to choose from, which all of us really, well, our antimicrobial stewardship team would say these are all appropriate to use. So selective reporting is really, really important. A lot of facilities don't do a great job at this. It's not required from an accreditation standpoint for laboratories, except for site-specific, source-specific selective reporting, but it is a really important thing for laboratories to do. Today, that's all we're going to go over. I will tell you, there's a whole lot more to talk about with susceptibility testing, D-test, and detecting specific tests for beta-lactamases or other susceptibility resistance markers. So there's a whole lot more to talk about, but that will have to wait till some other time. So that's what I've got for you.
This was excellent. Thank you. Thank you very much, Alan. Any of you have any questions, put them in the chat and we can take advantage of this time and this knowledge. So Dr. Ramirez, do you have comments, questions?
You know, again, as always, excellent. We are moving forward in the area of microbiology. And how common at this moment is you describe that laboratories rarely report MIC. You do the breakpoint testing, just particular area. Is this, I may say, the standard approach across laboratories?
It was interesting. There was just a question that was put on the Clin Micronet listserv, which is kind of like all the micro directors from around the world. just a couple weeks ago on do you report MICs or do you report just the interpretation? And I would say probably 75, 80% of those that replied report the MIC and the interpretation. It's meaningful to ID physicians some of the time. It's meaningful to pharmacists, especially ID pharmacists. I know the ID pharmacists would like to have the actual true MIC every single time. The MIC doesn't mean a whole lot when you're doing breakpoint testing. It really doesn't mean a whole lot. So I think there's a lot of arguments to say what docs look at is the interpretation. What they need to know is the interpretation. If there is a need to know the MIC, then we might be able to do additional testing to get that. But we decided, I like the MIC, I'm going to stick with it. So we report the MIC and the interpretation both.
Yeah, but in reality, it's not the MIC, you're reporting the breakpoint.
Well, yeah, because there's some differences there. For example, on our gram-positive panels, there's a pretty decent range. I think vancomycin goes from 0.25 up to 16. So we actually measure a lot of MICs there. And the reason for that is that the breakpoints differ between different groups of bugs. So in order to cover a whole lot of different groups of bugs, I have to have a wide range on that panel. So in some situations, it will be a little bit more meaningful. But my favorite one really is trim sulfa on those gram-negative panels, because there's one well. If it grows, it's resistant. If it doesn't grow, it's susceptible. That's it. So telling you the MIC really means nothing.
Do you have any questions, Ruth? Because I have several questions.
No, go right ahead. I wanted to.
The selecting reporting. Because
Yeah.
selective reporting is I don't want to say it's an art, but it's, you get out of science into an art of selective reporting.
Yeah.
And looking at our institute, that we have now the idea of trying to improve infection prevention and antimicrobial stewardship throughout Kentucky, and we try to develop some programs. And this selecting reporting is so important at the local level. But unless you have a person with your level of expertise, it's very difficult to say, okay, you know what, I don't want to give you this one, because this has such a legal implication that I'm not telling you what I got in the microbiology, that you need to have a lot of backup to say, I don't want to give you because you're going to do something wrong with the information. And it's going to be better for the patient if you don't know. But then how is this selected reported? How do you get there?
Okay. First of all, there is a table in the CLSI document that I didn't show you, which basically takes all these antibiotics for the enterics, for example. It'll classify them. It'll say class A are drugs that you should test and report on every isolate. Class B would be those that you should test on every isolate, but then report selectively. Class C would be those that you don't need to test on every isolate, just need to test as it is necessary. And then there's a class U, which are those drugs that you only do on urine isolates. So there is guidance on how to set it up, but it really needs to support the antimicrobial stewardship goals of the institution. So it's something that a micro person can take their CLSI document and come up with a plan. Then that needs to go through your antimicrobial stewardship group, however that's set up, to kind of look at it and say, here, what are the rules that we want to put in place here? How do we want to do this? So yeah, you do need, in a lot of smaller facilities, I've seen a lot of smaller facilities that don't do this, but they're often in places, where you have a med tech who's kind of in charge of microbiology, and they don't have the support from having an antimicrobial stewardship team or even infectious disease doctors to help them out with this. So it is something that you can start with what CLSI gives you, but then you have to go through your antimicrobial stewardship team for.
Oh, very good. As we move forward and try to help other institutions throughout Kentucky, this is going to be an important concept.
You know, I think this is also a very important concept. We also have a number of IPs from long-term care facilities. So they send labs out, they don't have that in-house relationship. And then we'll get back the reports and then try to figure out sometimes what to do, especially when you have reporting on drugs that you would not use and perhaps a lack of real familiarity with antimicrobial therapy. Can see that can be a real challenge.
It also takes some computer expertise because you either have to be programming your instrument or programming the laboratory information system to make these. Because, you know, I went through that example there, but we don't look at every single one of them and hand pick which ones we're going to report. You know, we have a set of rules, a very complicated set of rules that are built into the computer system. So they come across the way we want it to come across. We don't have to do anything except, okay, go.
I don't see any additional questions in the chat. I know we could go on and on. This is such a great topic.
There's one more thing. You meant, Dr. Ramirez, you mentioned about a legal thing with it. That's true. I have had some physicians just absolutely freak out and chew me out on the phone because we're withholding evidence, and I'm like, no, we're not going to do that. I would say a couple different things. One is that, if I remember them, we do selective reporting on the culture results as well. You know, we don't give you all the data. We look at the culture. If we have a sputum culture there, you know, it's our interpretation of that culture that gets reported. You know, you may have Staph aureus growing, but we don't tell you there's Staph aureus there because it's in a very very low amount. There's something else that's more important. So selective reporting takes place on the culture side as well as on the susceptibility side. There was something else I was going to say and I can't remember what it was. So,
how often you get calls from physicians to discuss microbiological reports? Because we always tell the fellows, if in doubt, call microbiology, talk to the microbiologist, because again, you see things that you don't necessarily report, but how often you have this interaction with local physicians, or they just give up?
You know, I get calls of some sort every day. Now, as far as doing that, as far as people saying, you know, could you tell me, you called this mixed flora. Can you tell me exactly what's in there? Doctors will call and say, I want everything worked up. You called it mixed flora, I want it all worked up. And I'll be kind of like, well, let me tell you what that mixed flora actually is. And then we can decide whether any of that really needs susceptibility testing or not. So those calls, you know, probably 2 or 3 times a week, I'll get something like that. We get calls quite a bit. Now, that was the other thing I wanted to say is, now that you all know that we had 29 drugs and only gave you 8, physicians do call and pharmacists call occasionally and say, can you release something additional? You know, for some reason, whatever that reason is, we want to use meropenem on this patient and you didn't report it. First of all, do call, don't just assume. Go ahead and call. If you're using meropenem, call and we'll see if we can release meropenem. Because if a physician calls, unless it's a really stupid ask, okay, which sometimes we've had people ask for vancomycin on Acinetobacter. I'm like, no, you're not going to get that. But unless it's a really, you know, stupid ask, then yeah, I'm going to go ahead and release something if you request it.
When you say release, for instance, I call you and you just tell me. In this case, whatever, meropenem susceptible.
I can do that. If you called and said, you know, we're treating this patient with meropenem, can you tell me what that is? I can say, sure, let me look it up. And yeah, it was susceptible. But if you're using it, then I want it to be in the report so that it's documented that patient that bug is susceptible.
In this time of multi-resistant organisms, and since you have the breakpoint testing, and for instance, you give the example of tobramycin, not equal or more than 8 is resistant.
Mhm.
And sometimes we have these multi-resistant gram negatives, and someone say, well, if I'm able to push the dose, or doing once daily and this or that, I may get there. Now, if then the question is, as you alluded in your presentation, how much resistant is resistant? Then it's a matter of calling you, and then when you say, okay, I'm going to do an e-test to see if the MIC is 16 or 32 or 64 or 200, because then we say, well, if it's 200 something, I will never get there.
Right.
If it's 32, I can play around with the dose and do something. Then the question is, how long does it take once we call? I said, in this case, we really want to know it's resistant, but we really want to know the MIC. How long does it take for you to get the bag, get the?
Okay, that depends on the drug, the antibiotic, because we keep on hand here probably about 15 different antibiotics on e-test. So if you're asking for something, if you ask for meropenem, no problem, I can do meropenem. If you ask for tobramycin, I'm going to say I can't do. I don't have an e-test for tobramycin. So we can either, one, send it out, you'll wait a week, or two, I can order tobramycin e-test and wait 3 weeks for those to come in. And
Wow,
do it.
this is.
Yeah, I can't keep all.
Yeah, we're dealing with a patient with a multi-resistant organism that we need to know if it's slightly resistant or very highly resistant, and it's difficult.
Yeah.
Yeah.
But we don't have all those available to us. I'd love to, but like I said, they're pricey, and if I order 100, then I'll throw 99 of them away.
Yeah.
But normally, if it's a drug that we have, then basically I need to have a fresh culture in order to do the test. So I might have to streak the bug out today and set it up tomorrow, and you'll have the result in 48 hours. If I already have a fresh culture, then I can just set it up and you'll have it in 24 hours.
I think that this has been, again, it's very important for all of us to figure out what happened in our own institution, but it's also important for us to be thinking when we get called from other institutions. And again, part of what we do here at the Institute is try to see how can we improve infection prevention, antimicrobial stewardship. Essentially, how can we improve patient care across the state of Kentucky? Then we are going to continue with these discussions that has to do with infection prevention, antimicrobial stewardship, antibiotic use, infectious diseases. Ruth mentioned this multiple times. If any one of you has any particular topic that you want us to discuss, please let us know. Otherwise, we are going to continue with this rotation. And Ruth, understand that this coming week is going to be a pharmacy topic.
Correct. This coming up this week, Dr. Ashley Wild will be talking about blood culture, rapid diagnostics, and antimicrobial stewardship.
Now you see, as we always discuss, this is a complete interaction. We are separating these topics in an artificial way. It's a complete interaction of microbiology, pharmacy, clinical practice, infection prevention. This is why in all our committees, we are all together trying to understand and try to do the best for the patient. Alan, as always, it has been a great presentation. Thank you very much. And thank you all of you for your attendance. Ruth?
Very good. We will see you next week. Thanks very much.